And welcome to our ICS board meeting in public, and welcome to any members of the public as well. I can't tell if we have got anybody there, but welcome to absolutely everybody. Just a few things to say. So for anybody who doesn't know, it does say on the thing, but my name is Catherine McLean. I'm the chair designate, I think is my title at the moment, of the integrated care system. And just as a few announcements really, and apologies and so on to begin with. I believe the meeting is correct, which is good to know. We've got apologies from Mel Barrett. I think we should have Lucy Hubber somewhere. Have we got Lucy who's represent? Yes, we have Lucy. I can see Lucy. Fantastic. You're representing Mel. And I believe that Melanie Brooks is going to be a bit late by 30 minutes from the county, so she'll join us. And
Melanie's joined us, Kathy.
Melanie has joined.
Ahead of schedule.
Ahead of schedule. Fantastic. Good to have you here. That's good. And I think we've got apologies from Hayley Barsby as well, Joanna. I think that's correct. Have we any other apologies?
We've not received any other apologies for the meeting, so I think we're... That's
brilliant.
Yeah.
A very good attendance. That's really good. So before we get into the rest of the agenda, just wanted to also note, and everybody will be aware of this, but Tracy Taylor has stood down from her role as CEO at NUH due to ill health. And I just wanted to register that here and, you know, for us to have a chance to say thank you to Tracy for the things she's done for our system in particular since she's been with us. She was taking a lead role on a number of things across the system. So you know, if we can perhaps send a message to her via Rupert to say that we have noted that, or Eric if he's with us. So thank you. Also need to say that actually it hardly seems as though we've got going, but this is going to be the last meeting in this format in public. And that's because, as we'll see on the agenda, we're going to discuss how the new system is being developed. We'll want to think about how we ensure we maintain our engagement across and between ourselves, but this formal meeting will no longer be, which is amazing to think of really. But by January, which is when we would have the next public meeting, we will probably have a shadow arrangement of the new integrated care board, but we'll remain on our toes about where we actually get to, so that we don't have a vacuum of anything, and we'll talk more about that, I'm sure, but I thought it was worth noting in case people hadn't sort of realised this would be the last of those. And again, before we really get going, I just wanted to also remind us, you know, to think about the principles and so on that we put at the top of our agendas and also our behaviours. And it's important that we keep going back to those things. We'll have a chance at the end of the meeting to reflect on those as well. So I think those are the things to get going with. Conflicts of interest. I'm not anticipating anybody's got anything new particularly to say, but has anybody got anything they'd like to declare in particular relating to this agenda? I'm not seeing any. And just remind everyone, if you do want to speak, you should have a raise hand function. Sometimes it doesn't work for everybody, and if it doesn't, put something in the chat, or you can try waving physically, frantically, but not every, depending on how many people are on the screen, they don't always come up, but do put something in the chat and just say you want to ask a question or make a point. That would be fine. And you should have had the last iteration of the declarations of interest register circulated anyway. Okay, let's move on then to the minutes. I'm hoping those are an accurate record. Has anybody got anything they wish to note? Have we got any attendances wrong or anything else? No. Well done. Good note keeping there. We can sign those off, Joanna. That's good. And in the terms of the action log, I think largely things are done there. And anybody else might want to bring up some things. I just wanted to make reference to, there was a couple of things that are way down on the action log that are still assigned to Andy Haynes. Well, they're not going to get done, are they? Because Andy left some time ago. I just wondered perhaps if I could leave it with Amanda. Could you just take a look at those outside the meeting and either work out that we're no longer relevant or assign them to someone who might be with us?
Yes, will do. Yeah.
To do that, that would be very, very helpful. Anything else, Joanna, on the actions that you wanted to bring up?
No, thank you.
Good. Anybody else want to raise anything on the actions? Nope. Good. Moving nicely forward then. So moving on to the next thing, if I can get my thing to move. Let me just move it down. Yes, so the next bit is a really important part of our agenda, and this is our citizen story. And I think John Bruin is going to lead us. Well, John actually isn't, I don't think. Or John, are you going to lead us into that today?
I've got a couple of lines, Kathy.
A couple of lines.
Hand over to the people that know what they're talking about.
That'd be good. So what we've got here is a story, and we're going to have a video, which I understand is going to be about 8 minutes, something like that. So we'll have a few minutes. I think if we go well, we'll have about 5 minutes for any questions and so on. But I think we're going to have to be just discipline ourselves a little bit to make sure we do get a chance for a few questions and so on that, if that's okay with you, John, and your colleagues. And I think we should welcome the other colleagues as well, if you could do that. I think we've got Chris Schofield at least, and I think maybe somebody else. John, do you want to pick it up?
Yeah, thanks very much, Kathy. John Bruin, Chief Exec, Knox Healthcare. Delighted to introduce the citizen story for this month, and thanks very much to the team for pulling this together. As you say, Kathy, we've got a video. This is a great example not only of the benefits of improving the experience of patients and service users that use our services, but also a great example of being able to shift and maintain care within communities and closer to home, which is one of the principal ambitions of the ICS. So I can't see Chris on my list of people, so I'm going to hand over to Helen Smith to just host this session, if that's okay. Helen, are you there?
Hi, John. Yes, thank you for that. So my name's Helen Smith. I'm Interim Programme Director of South Notts ICP, soon to be PBP. We're just in one room, so I'm just going to get Nicole to put her... That's better. Apologies for that. So I'm here as the Programme Director of South Notts ICP. You'll see Chris Schofield in the background with Jane, who is the patient and citizen who's sharing her story and very kindly agreed to be present at the meeting as well. Nicole Atkinson as our clinical lead, Diane Pearson as OT. Diane, can you give us a wave? And Paul Bagley, physiotherapist from Primary Care Psychological Medicine. Hopefully you've had a chance to read the paper which describes the service, and we hand over to Jeanette to put the video on, which should speak for itself. Thank you.
I was in a real bad place. I've had lots of ongoing illnesses and lots of operations, nearly 30. So each one's took its toll. Was diagnosed with quite severe back trouble, and since then I just sunk into it with really low mood. There was a lot of things that was coming out in me because I was so low, and these little boxes that I'd hidden away was opening up and I couldn't handle it, and so I was just not wanting to get up, and sometimes even not wanting to find a way through it, you know. I said that I felt like I was in the bottom of a well, but there was not, that light wasn't there. I'm just an ordinary person, but who's had a lot of bad luck, you know. And some doctors don't recognise that. They think it's you, and you feel like they think you're I think they think that you're just making it up or something, that you can't possibly have 30 operations and whatever. So I went to my GP, who I get on really well with, but she couldn't help me. She could see that I was way past, I was just crying all the way, I couldn't even speak to her. So she said, would you like to be referred to this team? So I said, yes please. When the GP told me about the team, I was too low to think that it would ever be possible to get out of it, you know. And then Mark the nurse came, and we started on the beginning, really. First it was hard because I had to delve in places where I hadn't been for quite a while, and I have had counselling in the past and not had that connection, but with Mark it was different. Initially I was too ill and too low and too cryy and too down to go out at any time, you know, at all. And then as the weeks progressed, talking to Mark, we was undoing these nasty things which I'd been trying to hide, and there's a little glimpse of light, and so to have Mark to talk to was like a miracle. And then I'm not just saying that, it was. At the time I was suffering with a really poorly shoulder. Paul came, the physio, and he gave me a lot of support with the shoulder and other support as well. He became like somebody, a friend, you know. We used to text now and again, you know, how are you doing, are you okay, and all that, and he used to come, not so often, but to help me with this shoulder, because I just couldn't use this arm at all. Because I'm in such a lot of pain with other things, the shoulder was just another pain. So he tried to prevent that from adding on to the pain, you know. Angela, the carer, she came and she got me out the house. I didn't want to go. She was having none of it. And she gently persuaded me to go for a coffee, didn't she? Yeah. So we went for a coffee, and amazingly, I clicked with her as well. So, I mean, how lucky is that, you know, to have 4 people who I bonded with, I think. Time when Mark came in my life and the team came into my life. Up until that time, I didn't really talk about the bad things, and I didn't really talk about the bad things to Angela, the carer. It wasn't all about sad things, you know. It was about nice things to think about again, to do my hair again, buy, you know, get fashion and holidays, you know, and all that kind of thing, which was really, it just took me out my house for an hour of just not thinking about what the pain and everything. I feel in a much better place. I've still got the pain, I'm still dealing with it, I've still got to sort things out that's wrong with me, but my mind, I can't tell you it in words, there's no words to say really. So it's sort of brought me up this well, and I've slowly climbed the well through the team. It's like, I think of it like there's 4 ropes hanging down, or 5 ropes hanging down this well, and I'm climbing up these ropes. That's how I feel, and I think I'm over halfway now, and then I'll be like 3/4 of the way now. I'm not at the light yet. I'm not completely better by any means, but I know it's a cliche and you won't believe me, but the team saved my life, and I really mean that. I still have bad times, and Mark's there and the team's there. Diana's got me a job, would you believe, in a volunteer job in Burton Joyce for one afternoon, and I'm so over the moon that I can do it. I'm in a lot of pain when I'm there, and they say to me, you look in pain, you look tired. Try to disguise it, and I said, look, I'm always in pain. If I was at home, I'd be in pain. Here, I don't have to think about the pain. I'm talking to the customers, I'm having a battle with the till. It's just an outlet that I've needed for so long. And it's a unique service, and it's needed so much to get out that well. You can't get out that well on your own. And my husband, he says, the difference in you, why you've been having the treatment, and the team, the whole team, it's been remarkable, and it's made his life happier and easier, because he's a carer for me. They've gave me, the team's given me confidence, and slowly, like a jigsaw, is being made. It feels that's how I feel, like a jigsaw, and the pieces of the jigsaw are being slotted in by all 4 of them or 5 of them, and slowly one day, hopefully soon, this jigsaw will be finished.
Thank you. That was an extremely impactful video, wasn't it? And thank you so much for being brave enough to come forward. John, can I just hand back to you for a moment? Anybody else in the team want to say anything, or do you want to add anything at that point before we ask if there's any comments or questions?
Yeah, thanks, Kathy. Thank you to Jane. That was a brilliant and, like you say, amazing courage to share your story. If I could go to Helen, I haven't got anything else to say. Thank you, Kathy. I don't know if Helen, anyone in your room's got anything to add.
I just wanted to add that I didn't introduce Mark, the liaison nurse who sat next to Jane as well. I'm very conscious that I went through everyone else, but didn't introduce Mark, but he's a key member of the team as well. He's there. But I think really what Jane's story has highlighted is the interdependency of mental health and physical health, and how by taking this very holistic approach, looking at the person as a whole, you can really make significant benefits to that individual in terms of all elements of their life.
Yes, we heard from so many different, I loved your analogy, Jane, about the ropes hanging down. That was brilliant. And the, you know, and building that jigsaw and so on. So I think that was absolutely fantastic. Can I just open this up in case there's anybody who would like to make any comment or say anything, because I'm sure this has got much wider implications, hasn't it? John Towler, and then Tim Haywood, and then Tillan.
Thanks, Kathy. So I clearly remember when we had this pathway presented as a patient story in June 2019. And it was incredibly powerful then, and it was incredibly powerful today. So thank you, Jane, for sharing it today. If it's okay, Jane, I'd actually like to ask a question of my colleagues, and I'm probably directing this at Amanda. It's a process question about how we're going to ensure that we become a dynamic fleet of foot integrated care system. So 2 years on from the presentation in 2019, this is still a South Notts service. So I'd like to understand what's prevented us from reaching the point of deciding it's a service which delivers great outcomes, good value for money, etc., and therefore doing it across the whole of the county, or concluding it's not and not doing it at all. It feels as if roughly still doing the same thing 2 years later is not where we ought to be.
Thanks, John. Amanda, do you want to have a go at that?
I will, thank you. So, John, I agree, and thank you, Jane. It was a really powerful story, and shows the sort of value of that sort of service, and how blending the boundaries between different services is really helpful. The service did go through a further, so initially it was in a very small area, and then it was rolled out to South Notts, as I understand it, across the whole of the place. And we did talk about potentially rolling it out further as well. When we looked at I think since that time, the way that we do planning now has changed. So it's not just in the CCG, it's actually part of the whole system. And I think what we'll need to do is think about this in the system space with all of the places there, and think about how we make the best use of the collective resources that we have. I know previously the affordability of it, in addition to other things that we were doing, was a constraining factor in terms of rolling it out across the whole of the patch, plus the workforce needing some time to grow as well with the relevant skills. So I think we need to look at this in as a whole system, as part of that system prioritisation process, and work out how we can integrate services like these with other services in local communities, and how it would work best in different places, because the population needs are slightly different in some regards. So some of the approaches might need to be tailored. So that's really just a bit of an explanation, but I think the way forward is to look at this as part of our overall system priorities as a whole. Thank you.
Thank you, Amanda. Can I just be a little bit challenging, if you don't mind? I'm not sure if it's where John was coming from, but if I'm thinking forward into a world in which places have primacy, what would stop the other places looking at this and saying, do you know, that's a really good thing to do? Can we just run with this? Can we just do this? Because what you're describing is still feels like a sort of centrally controlled thing. And I'm just wondering how you spark the fire across the others, and just pick it up if that's a good way of doing things, because the benefits were being put forward as, having a benefit downstream of costing less further on. I don't know, but maybe this is too much detail for now, but it's just a bit of challenge, I'm afraid.
And I think that does make a lot of sense. I think the issue was there were quite considerable investments required. That was the issue. Okay. So had that not been the case, that would have been. So I think and we have asked places to look at, certainly IAPT, and how how that whole pathway can be done. So So I think absolutely, I think working together and that, so I think that was the challenge. I think if we can work out how it all works together rather than have to keep layering on and sort of coming centrally for the, for more cash, that would be quite a game changer, I think.
Yes, absolutely. Thanks, Amanda. Now I've got 4 people. We'll have to draw a line under the 4, but we'll take these 4 comments. I think somebody's disappeared, but anyway, I think I've got Tim next, then Nicole Atkinson, Paul Devlin, and John Doddy. Tim.
Thank you, and thanks for that presentation, which was very moving, and the presenting that to us has been very, very useful and worth the bravery required. So thank you so much. This was a service clearly ahead of its time, wasn't it? Because what we're doing now at primary care networking level is building services that don't rely on the medical model to solve problems that are not solvable purely by the medical model. And I think the point I was making is that as we move forward with working across boundaries, this kind of service must provide for us a guiding light, really, to show how successful it can be to abandon the traditional silos and to realize that most problems are solvable by a mixture of models, and the medical model is not necessarily the one that can provide all the solutions. And interesting discussions I've had this morning in Beeston are that it's not just us at this table that need to understand that, but we need to make the new services such that the people who need them recognize that and come to a much more integrated service to solve their problems. And so I suppose all I'm saying is let's use this service and put it up on a pedestal and show it to everybody as something we should be very proud of, and something that was 2 or 3 years ahead of its time.
Yeah, good, Tim. Is that something we could do, John, and team? Is that something we could make a case study of and promote and all that? Can we leave you with that? That's great. Nicole, I mean, because there's more than one of you in the room, I don't know if it's you or not, but anyway, Nicole. We can't hear you. I'm not sure what the reason for that is. Can anybody hear Nicole? No. It doesn't look as though you're on mute, does it? But there's something wrong with the system. Shall you sort it out, and we'll come back to you in a second, Nicole. Can I move on then to Paul?
Thanks, Kathy. Hi, everybody. Paul Devlin, Chair of Nottinghamshire Healthcare. Jane, thank you so much for sharing those experiences. I wanted to just take a couple of your images and ask that we hold them during our meeting today. I've written them down, Jane. I think the getting out of the well and the importance of the ropes, I think there's something for us to be thinking about. How can we constantly think about how we're getting the right ropes in place and also helping pull you up, not just letting you have to climb. And also the jigsaw was a really powerful one for me, because what struck me was not only do you need to have all of the pieces, you have to fit them together in the right way to be able to get the complete image. And I think that you've given us a couple of really powerful visual challenges there. So I appreciate you giving us those. Colleagues, I would just put a plea for us to think as we go through the rest of our agendas today, that we hold those images, because I think they could be useful for us. Thanks.
Thanks, Paul. Absolutely agree with those things. That's really, really important images and ones we probably would not have come up with ourselves, I have to say. John Doddy.
Thanks very much. Can you hear me, Kathy? Excellent. John Doddy, Chair of Health and Wellbeing Board. Thank you very much indeed, Jane. Again, not only auditory, but very visual. It made everybody sort of see what you were going through, as well as listening to your story, which was remarkable. I do remember some years ago going to the Walton Institute of Pain Management, which was residential, and they had psychologists, physiologists, neurologists, and surgeons. And these things were so successful, but they were also so intense, people heavy, that they were taken away from practically everywhere else in the country, despite the fact that we knew they were enormously successful. It could be that some people don't need the entirety of the team. And in PCNs, there are social workers soon to be employed. We have pain clinics, we have social prescribers, etc. So we have a lot of the little bits of our jigsaw to put together for the patient. But what Jane's highlighted is that distraction is one of the world's greatest treatments for illnesses. Far, far better than anything that I can give in the form of an antidepressant and a painkiller. We've always known that people living on their own in pain and isolation have more medications than people who are surrounded by family and friends. And I think it's just another step out into the wider community, as Tim says, leaving our silos and recognizing that health and well-being is based in those little half a day a week jobs that give people a sense of worth and sense of satisfaction. So I think that it's just one of those things that we just need to take on board and run with. And thanks once again, Jane, that was wonderful.
Thanks, John. Very helpful. Nicole, I'm just wondering if you've managed to move into some way.
Does this work?
Yes, it does.
Except you'll probably get some reverb. I suppose I was just wanting to say that this signal doesn't really... Okay, I'll try again. The reason why it feels like we've struggled to look to either spread this is because actually this service doesn't fit into a box. It doesn't fit into a mental health box. It doesn't fit into a physical health box. This fits into a person box. This is about the person and all of her needs. And I think the other bit to say is it doesn't really fit with any of our existing services, because actually sometimes the longevity and the complexity of the patient's requirements are such that they do need that kind of intensive specialist support. So I suppose any help and support can give us to really, as Tim said, put this service on a pedestal, ensure that, if I'm honest, the thought of this not carrying on in South Notts, let alone across the system, I think would be a travesty. So anything you can do to help support us in the future would be gratefully received.
Great, thank you. So with all of those points, I'll just summarise a few things and say again, thank you so much, Jane, and also to the team who worked with you, but particularly with yourself. You very, very eloquently described the indescribable, really, and I think you have left us with some really powerful images. But if I just take us back to our principles for joint working, it maps to something some of the colleagues have said, and that we have said that we will put the needs of our citizens at the heart of the ICS. And I think, you know, as Nicole said, one of the reasons this has struggled is that we're trying to match it around our constructs rather than around an individual. And I think it's a really powerful message that we need to think about, and maps to later in the board meeting, a paper that Alex will bring forward on the engagement of our citizens. So I think that's an important thing. But just a quick summary of the things that I think I need you to take away. So we've agreed we'll keep those images in our head through the meeting. I am going to challenge again that we need to pick up the question of the rollout of this or something similar, appropriate to each place. And how do we use the messages from this in other things? How do we take those forward? And then I think, John, you have agreed to pick up the issue of a case study made of this and make it a bit higher profile. But do those things capture the essence of what we've heard and learnt from that very important message there? Thank you again. And if those who've joined specifically want to leave, feel free, but if you want to stay, you're obviously extremely welcome. So thank you. That takes us on then to the report from myself and Amanda. You've got a paper there. I think there's just a few things to say, because obviously we'll take it as read, and there is some overlap with the building the integrated care system in part of that paper, which we will come on to. But I think it's worth noting, particularly at this time when COP26 is taking place, the focus on our NHS Green Plan. And that's a really important thing. And I think as we move forward, you think about the impact we can have across our system. This is going to be something to give even greater focus to, of what we can do between us to improve the chances of avoiding climate catastrophe, really. So, Amanda, do you want to pick up any things from the report in particular?
Thank you, Kathy. There are just a couple of points to highlight. One is we are making very positive progress towards the transition into April. There's some sort of technical elements that we're very, very well on with the due diligence side of things, but also the more locally determined developments as well. A lot of progress there, and a lot of people taking really active leadership roles in developing places and other things. Vaccination is mentioned in the report, and I just wanted to highlight that is really key to helping us through the winter period, not only for COVID boosters and young people, but also flu as well. So that is a very active programme there, really critical as we go into winter. And I think it will be a recurring theme through a number of items today that the system is working under really considerable pressure across health and care. And there is a huge amount of work again across the system to maximise capacity, help processes work as well as possible between the different parts of the system. We are looking at, again, as a system, how we can enact further change. So I think just maximising our existing operational processes isn't going to be sufficient to get us through winter. So we are really using our collective efforts to think what different things we can do as ahead of winter. And that will help us to address the COVID demand on top of the other demand as well, and needs people have. And then I just also wanted to mention around general practice, who are also under significant pressure, and just to say we're working with practices to help support some of the access issues that are sort of prominent in people's minds, but also to make use of available additional funding that we have this winter to support face-to-face access to general practice. So thank you. There was just a few bits to highlight, Kathy. Thank you.
Thank you, Amanda. And I think some of the things we'll come on to in the next paper, won't we, around building our system, getting ready for April. I'd just like to endorse what Amanda said about primary care. I think that every bit of the system's under a lot of pressure at the moment, but I think primary care is particularly so, and has not necessarily had all the best coverage in the media and so on. And I think we need, as a system, to be very supportive of our colleagues who we know are working extremely hard at the moment. So I know I've written something in a blog, and I think we've written out to colleagues to say that as a system we are very supportive, and we all need to work together, I think, as to alleviate those pressures. So I just wanted to say that. Is there any questions at all on the report there? Any particular things anyone wants to highlight? Hopefully it's useful information to keep everybody up to speed. So let's turn now to the next paper, which is about this development of the ICS. Probably a few bits for me to say, and then probably again, Amanda, you want to come in and add, I think. So I think, it is, we've got a few things we need to actually do. We've got to actually agree some things through this paper. We largely note the contents, but we do need to look at the naming convention for various bits of our system, whether it's the Integrated Care Board or the Integrated Care Partnership, and we need to ideally agree those, or if people have got better ideas, agree those, but we do need to ratify those. And that is a process that's going on nationally. And I think, as you can see, we're basically sticking with Nottingham and Nottinghamshire, whatever it is. And if anybody has any better ideas, that would be really good to hear. But it seems the best way from our perspective, and the most inclusive way for our whole system. I think the other things I would just mention are that you'll be aware that in order to get ready for April, we're going through some processes of getting people into post. And as I said earlier, I'm the chair designate is my role title at the moment. And at some point, I guess that will become moved from designate to actual. And we've been going through processes around, as everywhere across the country has, appointing a CEO. And that's a two-part process. There's a local process, and I know some of you've been involved in that. And now we're waiting for the national part of that process. We believe we will hear within the next week or so, maybe a couple of weeks, that we will actually hear what the outcome of that is, as will everybody else across the land. So we then are obviously moving forward on developing what will be the Integrated Care Board. And I think we're in the far stages now of our engagement on that. We've had various sessions as this board, haven't we, in development to look at that. And I think most people should have received a letter. We've had some useful responses, but I think we are very near now to being able to say what our initial Integrated Care Board will be. And at the moment, it looks as though that will be a size of 14 people. But as you will recall, I talk all the time about my inverted pyramid, and the ICB and the ICP at the bottom of that, and the population at the top, so that we don't get hung up on everything is all about the Integrated Care Board, because it's not. Place, as we've just been hearing about, is extremely important. I mean, broadly, though, we are on track, which I'm pleased with, because I think there's an awful lot of work to do. And I would like to thank those who've been working really hard on this. And I know Rebecca and a number of other people are putting, and we're very lucky to have Lucy Branson to help us with that governance work. But I know everybody has been inputting to all of this. So I think Integrated Care Board, I think we're pretty well there. On the Integrated Care Partnership, I think we've got a session at the end of the month in which we will all come together to discuss again. Is that correct? Am I right, Rebecca? I'm looking for you to not. Yes, she's nodding. This is good, because I get my dates mixed up quite easily. But anyway, end of the month. And thank you to Melanie Brooks for your input in particular in this, and that's going to be really important. And my principle that we've all talked about now is that this will be our guiding mind. This is the bit that will actually create the strategy that we'll all own, building on the JSNAs and health and wellbeing strategies. So overall, I think we are definitely in a pretty good place. And our system development plan, we've had good reflection back to us from NHS England, an improvement. So just before we open that up to other people's comments, Amanda, anything you wanted to add on that?
Thank you. Just to say that in terms of if you like, the nuts and bolts of the new system for April, I think we're moving ahead well on that. Just to make the point that this will be the end of the beginning for April, we fully anticipate that things will continue to develop and evolve quite considerably. And also to say, although the technical side of things is quite considerable and is in hand, I think it's going to be the OD and the cultural development over the next few months and years actually that will really determine our success. Thank you. Those just a couple of added points.
Yes, thank you. And I think fairly soon we'll be able to share something more about the responses that you've all fed into the OD assessment that we were having done, that sort of initial diagnostic, really. And Rebecca and I heard from them the other day, and I think we'll be able to do something with that and then develop I think, a whole range of different OD things, and some of that will need to be place-based, some of it will be broader systems, there'll be lots of different elements to this, because at the end of the day, we can have a structure, but what's going to make the difference here, this once in a lifetime opportunity to make a difference that we've been given, is how we work together and how we change and do things differently. Because if we carry on doing what we've done, we will be in the same position. We will get what we've always got. So we need to change, and we will only change if we are all bought into a clear vision, clear purpose, and we know what we're all about and what we're doing. So the OD piece will be something we'll all need to engage with. It sounds really boring, doesn't it, OD? But it's actually about how we become part of something different. And back to that, putting the citizen at the heart of what we do is going to be critical. So a few comments and questions I can see. I've got Adele, Melanie, and then John Doddy. Adele, over to you.
Hi, thank you. Good to see everyone. So a question and then a sort of further point. I'd like to ask a question about the route we envisage for the Constitution's development. It may have been raised before, but I don't quite remember the route for that. And then just if you're happy to take any comments about sort of in broad stroke terms about the shape of the board at this point, I would just broadly would welcome, I know that we can have input from public health and from and that we have to have input from a local authority representative with who holds sort of the statutory responsibility for social care. Though of course I would hope that in bringing that, whoever they are, they would bring with them I'm sure they would, the context, the sort of the city, the county, the patch context, because obviously local authorities are involved in much wider areas than social care. So just on that point, I think it's really important for a system like ours to have representation from the county and the city. So, understand to bring that picture of the two very different demographics, because they're not representing a city. They're not representing a service or provider. So would obviously bring that understanding of the particular challenges of their patches. So just making that in general terms at this meeting. I know we'll have other opportunities to pick it up, but thanks. Just thought it'd be a good point to raise at this point.
Absolutely, Adele. And so where we've got to in the letter that we've sent round to outline what we see as the ICB includes both the county and the city, and the requirement there is that those are officers. That'll be different on the integrated care partnership. Potentially different. We can have additional people, but on there will be an officer from, if you agree, anyway, an officer from the city and an officer from the county. The minimum we required was one, and we've got two. So why wouldn't we have two? So that seems sensible to do, and that's so we would pin that in terms of the Constitution. And again, Rebecca may want to come in and just say something, but yes, absolutely. So the makeup of our integrated care board is part of our Constitution, and so part of this is a major part of what we've been engaging around and getting people's input through workshops and then the further correspondence. But we will have to go through a process whereby our Constitution gets signed off at NHS E&I. Rebecca, do you want to just remind us of the process and the timeline for that?
So we've currently sent an email out to all colleagues asking for any final and further comments on the local proposals by the 10th of November, please. We need to get our response to NHS England the following week. And as part of that, we need to be confirming the engagement that we have undertaken, including through our ICS board development session and through the further engagement, including the recent communication. And we need to be really showing as well how we've reflected that feedback in finalising our plans for the Constitution as well. So if anybody's got any further and final comments, if you could send them through to us at the earliest opportunity, that will enable us to look at those and determine how we best ensure it's meeting the needs of our local population and really taking account of people's thoughts and views. So that'd be really helpful. Thank you. Kathy, you're on mute.
I thought I just clicked it off, but thank you, Rebecca. Just in terms of the totality of the Constitution, I suspect Adele also means when will we see that, for everybody?
Sorry, so we need to work on this in 2 stages. So the board composition's the first piece, and then after that, towards the end of November and in December, we'll be working with colleagues on the next stages as well. So that will come straight afterwards.
Absolutely. So we will share with you everything as we go along. So the only bit at the moment that we need to make sure everybody has engaged with actively is the makeup of the Integrated Care Board, and we'll address the ICP bit, as I say, towards the end of the month, and we don't actually have to have that in place, bizarrely, really, in my mind, till September. I think we are going to be ahead of that, frankly. I think we will, or certainly not till April, and then the strategy by April. I think we'll be possibly ahead of that and able to do something in shadow form that I'm quite ambitious around that, really. Melanie.
Yep, so first, quite a technical bit. I think there is a little bit of an issue from a local authority officer point of view about how the ICB guidance is being framed in terms of what a DAS can and can't do. So I think, Kathy, it might be helpful to escalate up through NHCI routes a bit of attention there. I have done so through our legal route, but this is a commonplace issue right across the country. So I don't think we need to reinvent something if somebody else has already examined that. So it's just to sort of flag that I'm seeking that advice. So sort of parking the very dull bit about governance, or it is in my view, sorry. I just want to give the board a bit of assurance about some of the process we've been through in terms of the engagement. So certainly from a county view, and I know Councillor Williams, has been similar conversations in the city. There's some elements about this that we're really quite excited about in terms of the county council, and particularly shaping the role about our populations and places, and how the elected members, the Health and Wellbeing Board, place-based partnerships and the Integrated Care Partnership will relate. So we had a session yesterday, which I think went really well, with our place-based partnership leads, clinical leads and programme director leads. And I think that started off a really healthy conversation about how, as we develop the Nottinghamshire Health and Wellbeing strategy, and I know that there's a similar process going on in the city, how we can make the most of that to ensure the places are informing that, as well as taking away responsibility for delivering as in their role in the system, in addition to shaping the strategy. So I think it's all starting to feel like it's coming together a little, and I'm really hoping we don't get too bogged down in some of the processy stuff and lose sight of the quality of those conversations. But just to give a bit of assurance, we're having lots of live discussion, lots of people involved behind what looks like quite a, I suppose, no offence, Amanda and Rebecca, quite a dry paper. That's sort of, there's a lot behind it, isn't there? There's a huge amount of effort and conversation behind that.
Yeah, and thank you, Maddie. And I kind of want to apologise, but in a way I can't, for the fact that we've got a certain amount of this rather dry stuff we have to do. And I think I said early on in the process, we would try and do it transparently, but avoid you having to do more on it than you need to. But today is one of those moments when we just happen to need to. But I agree, this is the opportunity around those conversations that you had yesterday and others that we can have. So let's push forward on those and get this bit done transparently and properly. But then let's move on to the interesting things. So that's very helpful. John Doddy.
Yes, John Doddy, Health and Wellbeing Board for Nottinghamshire. It's almost like a euphoria starting to develop around at the moment with all the positive thinking that's going on. I have to say that I would agree with the progress that's been made on the ICB board and the ICP towards the latter end of this month, going to have further discussions In terms of the Health and Wellbeing Board, since 2012, we've been developing strategies, we've been developing concordats, we've been developing system-wide interventions, but never in the last 10 years have I seen so much of the system coming together in a way that is a unique opportunity, as Cathy says, and one which I think everybody will benefit from top to bottom. As a GP in Stapleford for over 30 years, I can say that I have never seen an opportunity where there's been so much communication between primary care, between secondary care, between councils, between borough councils, with the sharing of resources, the sharing of information, increasing the platform of delivery of services. And that now seems to have a natural flow from top to bottom. It's as though somebody's removed all the obstacles, somebody's taken the parallel lines and turned them into a beautiful circle. And the same thing that happened to Mary in her care at the very beginning, where all the pieces of the jigsaw came together, all the pieces of our jigsaw are slowly coming together. And I share the real positivity that's around here today. Very exciting, and I share your positivity there, Cassie, of the progress that we're making together.
Well, thanks, John, and I really appreciate you just sharing with us some of the things that are going on. Interestingly, just prior to this meeting, I was meeting with Rosa and Stephen Short. We were talking about clinical and professional leadership and so on. It was a very inspiring conversation, and I think Stephen, I won't get his words quite right because he's quite eloquent on these things, but he was sort of saying that actually, you know, and I agree with this because for 20 years I've been hoping for this moment, but he was saying that, you know, previously we had all these barriers in place that as to how we couldn't do this. And now that the barriers are being removed, yes, or at least changed, to be honest, this is our opportunity. If we don't make something of this, we'll end up with the only people to blame is ourselves. So this is both an opportunity, but with it comes a huge responsibility to make something of this. And I think it is very exciting. And I am absolutely convinced that we here in Nottingham and Nottinghamshire can do this as well as anybody. I'd like to think better than most. But it's only going to be through that engaged, ongoing, both discussions, but turning those discussions into actual action. I think our citizen story just struck me as, you know, we'd stuck with the reasons we couldn't do it elsewhere. And I'd rather ask, what would it take to do it? And turn it around into positivities all the time. So I think we have a huge opportunity and platform. I think we've a lot of work to do, But the other thing that Stephen was saying that I was really struck by is, in order to get everybody engaged, they need to believe they can make a difference. And if you believe you've got a vision, you know where you're going, if you believe you can make a difference, there's a big chance we'll actually do it. So, you know, I think we need to keep that strand of positivity, because later in the agenda, we will talk about some of the things that are more challenging at the moment. And to ride above those and get through it, we need to keep the positive image. So, sorry about that, it was a bit of a sort of a moment, but I just, going on the back of John's comments there, I just wanted to share that. So thank you. Right, in terms of, can I go back to the paper then and just say, are we now able to do what we needed to do on this paper, which was agree to the naming convention? You can see it set out there for the ICS, Nottingham and Nottinghamshire, NHS, Nottingham and Nottinghamshire Integrated Care Board, NHS Nottingham and Nottinghamshire for the public name of the ICB, and for the ICS there as well, and so on, and the ICP, but put tagging on Integrated Care Partnership for that one. Is everybody broadly happy with that? Anybody got any other thoughts? Because if we're happy with that, we can support that, can't we, and agree it and send that on up to the national people, Rebecca, presumably. Is that right? Perfect. And to note the progress for the rest of the paper, I think is all we need to do today. So that's excellent. I'm going to move us on, unless anybody's going to stop me, to The next item, which is a really important item, again, and something that helps us get closer to the front line. And Alex, I think you're going to set us off on this. We've got a paper and then an attachment, which hopefully everybody's been able to read the more detailed document as well. We have a number of recommendations we need to follow in a moment when Alex has had a chance to introduce, and we've had some questions. So over to you, Alex.
Thank you, Kathy. I'm just going to introduce this for sort of 2 or 3 minutes. So hello, I'm Alex Ball. I'm Director of Communications and Engagement for the ICS. This paper and discussion follows on from the discussion that we had at our development session as a board in the middle of September. And the paper sets out our proposed approach to working with people and communities, as it's been termed, in line with the aspiration of our system to be a real sort of beacon for best practice in this space, and also building on the guidance issued by NHSEI at the beginning of September. So fundamentally, this is a set of proposals, a kind of roadmap about how we're going to listen to and work with citizens as citizens in their everyday lives, and using the intelligence that we gather from that to help guide the work of our system. So alongside the financial, the operational, the clinical considerations, all of which are really important, I fundamentally believe that the voice of the citizen needs to be heard much more loudly, clearly, and systematically in our system. So I make no apologies. This is a really ambitious and quite wide-reaching set of proposals. It's going to take quite a lot of effort to implement it ahead of next April, but it'll also take some time after that date to be refined and sort of course corrected over the coming period. It also, and it's one of the kind of key recommendations in the paper, it does need input from partners all across the system. This is a collective effort, as with all of our work. Much of the work that this paper signals will happen at the level of place-based partnerships. So there's a real collective role to be undertaken there in communities that our citizens kind of can understand and grasp. But also this is a two-way process. This proposed approach gives us a real chance to better promote and celebrate the work of our system as part of that two-way dialogue with communities. So I will just quickly headline the sort of key proposals. All the detail is in the annex to the paper. But broadly, there are 5 elements to our proposed approach. There is some governance stuff we need to do. I wouldn't go so far as to call that maybe boring or dry, as other colleagues have done. I do think it's important that we get the right structures and bodies in place. But in some ways, that's sort of the least important part of the proposals. Much more critically to me, there's something about how we embed our work on community engagement, how we hear from our citizens and communities in all of our work, and is really sort of incorporated into our business planning approach at all possible stages. And to do that, the third sort of element is around really generating and using intelligence from communities. So there's a whole spectrum of different techniques, methods, activities that we can use, and the paper calls out many of those. But that will include working with elected members, working with the voluntary and community sector enterprise, working with statutory partners like Healthwatch, and developing some new activities like some kind of citizens panel or other type of activity like that. So we have to draw all that intelligence, all that information, almost, you know, we heard Jane's story right up top. We need hundreds, tens of hundreds of those every month being kind of drawn into our intelligence. And then we need to really integrate and synthesize all of that information. So to do that, there's a proposal that we create a practitioners forum. That's about bringing together all the colleagues across the system who work in this space to make sure all of our work is joined up and integrated. And then creating a hub for all of our insights, essentially a database that can be a system-wide resource that brings together everything we know about citizen attitudes and expectations to help feed our planning and our strategizing. And then finally, we have to develop our culture. And again, we've touched on this already today. In many ways, I think this is probably the most important part of the whole set of proposals. If we don't start to turn our approach almost upside down, in line with that inverted pyramid, away from a sort of institutionally led top-down approach into a much more citizen-led one, then I do think we've missed a real opportunity as we step forward into this new system. I could go on for a lot longer, but I hope colleagues have had a chance to read the detailed proposals. This is ambitious, but it's in line with the national direction of travel in terms of policy, and I do think it's one of the really key building blocks for our system from next April and beyond. So there's 3-4 asks around endorsing this approach, a real kind of request for individual organisations to sort of really commit and make sure that the resources and the efforts all across the system can be put forward into this. There's some bits and bobs of interdependencies and some various bits of work that we need to do to tidy up some of the interlocking elements of this, that there's some suggestions about how we do that, and then 1 or 2 other next steps that would be helpful to be endorsed. But yeah, that's everything I want to say. Thank you, Cathy.
Thank you, Alex. There's a lot in this, isn't there? And I know we've got a few questions, comments coming up. Let's take those and then come back to the next steps and the recommendations. So I've got Tim, and then I've got Michael, Williams, Claire, Hugh, Adele, and Lucy. So I've got lots of people. So.
Hi, thank you. I think it's a great piece of work, Alex, and I'd like to get behind it and offer any help that my PCN and other PCNs in South Notts could do. I think we had an inspirational talk during the Community Transformation Programme from Mark Spencer in Fleetwood, in which he described how community engagement had happened in Fleetwood. I think many people would be familiar with that. The key thing, I think, though, was that they tried not to use the phrase engagement, because they wanted the communities to lead, not to be engaged with, but to actually be the leadership. And I think that fits with the inverted pyramid model very well. And I think we're trying to achieve that in Nottingham West. The phrase that stuck in my mind that he said to us was, in 10 years of engaging with my community, not once has the community asked for reduced ED attendances. What they asked for was education and employment opportunities, and by delivering that, we've reduced A&E attendances by X%. I can't remember the percent. And I think that's so important, is if we genuinely are brave enough to allow communities to lead us, but not to be engaged with, then we can make achievements like that. And I think that needs to happen at PCN level. I know what's happening in my PCN. I would be very keen to have board commission some kind of understanding of what's happening at that neighbourhood level, because I think that's where workers work together, and it's where our communities, who in the end must self-define. I think that's the second point I want to make, is if we force our definition of what a community is on a community, then we will end up putting boundaries on groups of people that they may not recognise themselves. But if we actually allow our communities to self-define and then to lead us, I think we can properly invert the pyramid and make some real progress on this kind of basis. And I would be right behind it.
Thanks, Tim. I have to say, I completely agree with you. I think this is about doing something very different, and engagement. And it's the same with various groups. It's not engagement, it's about them leading. So I just wonder, listening to that, Alex, whether or not there's any wording you will need to reflect on in that. But I'll leave you with that just to think about. But I'm very glad you support this, Tim. That's great. If I ask Michael next and then Claire.
Yeah, a very positive approach, I think. I sort of endorsed Tim's points as well. I had 2 specifics. One was, and I may have missed it, whether there's any reference in the document to expert patient programs and the sort of contribution that patients with specific conditions can make to having a general dialogue and being able to reshape services so that they more meet their needs. There's some very good examples, I think, in Nottingham and Nottinghamshire and in other parts of the country that could well be built on. The second was really trying to link together some of the aspects of communication, engagement, and the sort of coalition of interests, if you like, at the place level. and how important it will be for and building on Tim's point, not just listening to what people are saying, but also giving them a leadership role in reshaping some of the services and the way in which we deliver those services. So I think some of the wording is quite important to be able to give people the confidence that it's not only a question of listening, it's a question of reshaping and leading those sort of views. But come back to the first question, really. Have I missed it? Have we not included expert patient programs?
Okay, thank you. Alex, quick answer on the expert patient question.
It's in there. It might not literally be written in the paper, so we may well have missed it, but absolutely, that is one of the many sort of ways that we will hear from people in that whole kind of spectrum. So we'll make sure it's definitely in there, but it's certainly in our thinking.
Yeah, make sure we get that in. I think that's important. But I think we keep coming back to this thing about, how do people get a chance to lead, and what difference do we make to all of that? I'm going to move on to Claire now, and I'm just going to turn a light on while she's speaking.
Thank you very much. So I think there's a huge amount in here, and obviously very important that we engage with our citizens right across the system. But unless I've missed it, there isn't a reference to governors who are already involved within foundation trusts, and we've got 2 within the system already, and they are people who have already committed to engagement around support patients, working with the local community, and I'd like to see some way in which we try to bring those on board formally, but also to find a way in which we recognise that foundation trusts have a membership, and therefore those people have already indicated an interest in what happens with healthcare in general. I think the second point is in relation to how we talk about the NHS and how we talk about these things. I think if you went out to any part of the community, walked out of Kingsmill Hill and walked into Ashfield and asked them about ICS, ICPs, PCBs, any of those things, wouldn't have a clue what you're talking about. And I think that whole language of the NHS and what it is we describe and how we describe it and how we come up with a kind of colloquial terms, we've just agreed the legal terms for what we do and who we are, but what is the shorthand? What is the way in which we're going to get people to relate to what we do into their ordinary everyday lives and their relationships and interactions with health and care services?
Okay, thanks, Claire. I think that latter point is maybe something, Alex, to go away and think about is how will people, on the whole, I don't think citizens and people, others may disagree, I don't think they really notice, what the different structures are, I think, but can we do something to help with that? I think governors actually are in the paper. I thought they were when I read it, but
they are, and they're again absolutely in our thinking. So yeah, I can confirm that.
I think the point about the membership of the FTs is a good one, though, because there'll be thousands of people who are members actually. So I think that would be a good thing. Anything else on those points, Alex, to come back on?
No, I think that's really helpful. The governors are, as I say, we can certainly think more broadly about membership as well. I think that's another kind of strand of our whole spectrum, isn't there? Yeah. And absolutely, Kathy, the proportion of people who know about or frankly care about our internal nomenclature of different bits of the NHS is vanishingly small, but we need to be able to describe to them really clearly in terms they do understand about the services they care about and how they access them. So that's going to be the focus.
Thank you. Hugh.
Thanks, Kathy, and thanks. It's a really helpful paper, really. Just 2, I think, comments from me, really, building a little bit on what Tim said at the beginning. Delighted to see there's quite a focus on communities, not just individuals. A slight concern is sort of take us into that classical NHS deficit sort of thinking, NHS deficit model. And I think it's important we listen to our individuals and communities, not just what's wrong with them, but what's strong with them, and work on building them rather than using organisations to fill deficits, because they can often fill the deficits themselves as communities if we support them. So just a little bit of tone, and not what's wrong, but what's strong, and building the strength of our communities. Be very interested in. And the other little bit, sort of flicks me to sort of Kathy sometimes talks about a golden thread in the little diagram about engagement across the system. Place, you have representation in our place-based partnership boards. I think very much that in the city we're trying to sort of move perhaps beyond that into that, that golden thread of that co-production that you talk about, Alex, throughout it. So building on our learning from SSBC, for instance, if we think about our SMD, we're doing some procurement where we've got people with lived experience as part of that procurement board. We're doing some job interviews. We've got people with lived experience as part of the panel for job, and actually making sure that sort of lived experience is sort of a thread in everything we do, not just on the board. And I know you're trying to achieve that, but I think it's important. And I think we're trying to sort of move perhaps a little bit away from that representation just on the board to a much deeper ingrained sort of engagement, and actually that genuine co-production. But otherwise, very supportive. Thank you.
Thanks, Hugh. Those are good points too. I mean, one of the things we need to do is live the business of having the citizen's voice at all levels, so that we actually bring that into all our decision making as well. So I think there are some things about how we really do that, which is probably for us to think through. But any comments on any of that, Alex? Back to Hugh. Is it just happy to absorb that?
I think it's great. I think you and I are of a similar mind on this for sure. So yeah, really content with that. Thank you.
Okay, I'll move us along. Adele and then Lucy, and then I'll try and wrap up this one because I get the sense of general support here.
Yeah, thank you. I mean, obviously, always supportive of involving people and hearing, and certainly really like Tim's comments, which I completely agree with. I think so. I still read this as quite NHS-y. For want of a better word, and I think, but I apologies for the shouting in my house, but I think it's important to recognise and lock in the role of the health and wellbeing boards, and for us, there's a reference to a lot of this happening at Place. So for us, I think the health and wellbeing board, we want this to be the place, like the kind of both the engine and the MOT of this stuff. So it's where it's the route through which lots of the listening, hearing, acting happens, and where the assurance that all of that is taking place. Because I think our citizens know extremely well and understand extremely well what the impact of the wider determinants are and what the impacts of quality services are. And we are obviously a city extremely challenged by deprivation over, and frankly hammered by austerity. So I think our citizens absolutely get this. And as at Health and Wellbeing Board, that's the place where we hold the responsibility for both. I think we have a moral responsibility to co-produce those outcomes that we want to seek, and to co-produce the way that we get to them. And we'll need to know that Health and Wellbeing Board is the place where, for Nottingham City, where that happens, where people can hear our progress, hear who's responsible for pushing forward that progress, and where those partnerships are that are making it happen, and then assess whether they're doing it, and also think about what they bring to the table. I think Hugh's point around strengths and assets in the community is really, really important. We've got a tremendous amount to work with there. So I would, I think, obviously supportive of engagement, but also wanting to make sure that when we come to the final strategy, we are thinking about the way that our system work and work at all the layers, at place and at neighbourhoods, kind of locks into the existing resources that we have in, so we've got, in both councils, we'll have tremendous sort of community, well, probably reduced, but we still have lots of points of contact with the community and community development work going on in lots of different ways. So we've got all of those contacts with citizens and groups, and we need to make them work for the betterment of everyone's health and well-being.
Okay, thank you very much. Alex, can we just ask, because I'm just conscious of time and realize I am drifting somewhat behind my allotted time here, but could I ask you that you pick up those things from Adele? And I think the point about the language and everything, I think it'd be well worth making sure that you've run that past people in Adele's team and people in, if you talk to Melanie perhaps for the county as well. Let's make sure we use all of that knowledge and so on, and let's pin it into those current organisations, like the health and wellbeing boards as well. So if I can leave you to action that, I think that would help us on our moving time. And finally, I'm going to come to Lucy, and I will wrap this up, and I'll be looking to others then to help me with the timing on the next items.
Okay, I'll try to be relatively quick then, Kathy. Alex, thank you for taking us through this. I think you brought a richness to it that I perhaps didn't get from the papers, and I think one of the points that I think is really important for us to be very clear about is how brave we have to be with qualitative data, because we have to be willing to accept a much lower number of, a much smaller number of data points, but that they provide us with much richer insights than quantitative data. And so we have to get more sophisticated about the way we work. You talked about tens of hundreds of Jane stories. That's useless. That just becomes quantitative data. What we have to do is be able to trust and listen to 10 Jane stories and be able to find the connecting points, the things that make a difference. And to hand some of that responsibility over to the Janes to say, what would be more, what would be different. So I think there's something in your paper. You've talked about setting up a unit. I didn't see the connectivity with the SAIU and how we're going to bring intelligence into a single function and provide parity between quantitative and qualitative. And just building on Adele's comments, I'd really welcome the opportunity for place-based partnerships, the Health and Wellbeing Board, to be able to direct and lead their own co-production and engagement that meets the purposes but might not have all of the frameworks that are in there, so long as we're achieving the aim. Because it does feel, picking up on Adele's point, it does feel quite NHS constrained. We've got the systems and the processes, rather than using the richness of what already exists within partners in terms of the way that we might engage differently. So there's something about not constraining us and putting so many structures around ourselves, but to allow 1,000 flowers to bloom, so long as we're trying to do the end point, I think.
Thank you for that, Lucy. And I think we'll map some of that into the sort of next steps and the recommendations. But I think one of the big messages from both yourself and Adele is that we need to go around again, I think, and make sure that, there's been quite a lot of engagement in creating this, Alex, hasn't it, with a range of people, but I think we have to accept that it's possibly just a little bit too NHSy, and it needs that linking into the structures that already are. I think local authorities are much better at being close to the citizens, and the places there give us a chance. So if I can let you do that, so I get a sense of sort of broad support. So let me just do the next steps. Continuing co-creation of this, I think that would be helpful, and we need to kind of see where we're going to get to in terms of timing, because at some point we need to agree this and sort of sign it off, don't we? It's not quite ready for that because there's a bit to be taken from today, Alex. So I think there's really good support for this, which is brilliant. And then you're going to have implementation. You're going to develop a strategy and so on, so forth. So I think that needs to be noted. And something set out in your proposed approach, etc. I wasn't sure, to be honest, about item number 20, the CCG's internal audit programme. I'm not sure how relevant that's going to be when it no longer exists in April. But I think we perhaps ought to take that and do something else. Perhaps Amanda can help with that particular item, because I don't think referencing what the CCG is going to do is going to have much longevity, really. But I think I know what you mean. You know? So perhaps you could, between you, just work something on that. So the recommendations, which is the bit we need everybody to sort of sign up to. So the ICS board's asked to endorse the overall approach. Can we say that we endorse the overall approach, noting the comments that people have made, and that this won't be the final time to see it? Is that broadly okay? Any objections to endorsing the overall approach? Nope. That's
I think
brilliant.
Well, I think with those caveats, yeah.
Yes.
But just that we absolutely need to make the links to health and wellbeing boards so clear. And think about the sort of the relative weighting and the relationship between the data we get from one place to the data we get that comes through the health and wellbeing board channels.
Yes, and the trick is to join all of these things up, isn't it, really? But Alex, you've got that point, haven't you, to bring into it. You can always talk to Adele offline as well. And then organisations are asked to commit to the expectations outlining the requirement for system-wide resource and activity. I'm not sure whether or not people feel able to commit at this stage, because I think we probably need to see the final thing, because I think what would be quite helpful is if people can start to discuss it within your own organisations at this stage. Alex, do you want to flesh out what that commitment would be?
So the main thing is the sort of almost the kind of intellectual commitment or the philosophical commitment that we'd want to come together and work collectively on this. We don't quite know exactly what that will mean in terms of actual resources of people's time, but I wanted to kind of signal to the board that there's a lot to do here. It is an ambitious plan, and that we would be looking to create a couple of ways through the practitioners forum in particular of bringing people together to collectively work on that from all organisations. So that's probably the commitment I'd look for now. And we can certainly bring back some more detail at a further time if there's more specific requests.
Yeah, so are people happy to commit intellectually to the principles? Yeah, I think in terms of any resources required, people would need a little bit more information as to what they're committing to. Is that
of course
fair?
Yeah, no, absolutely. And I'm not asking for a commitment of resources. It's the stepping forward into a collective endeavour.
Great. Sounds good. Sounds good. And then 23 is endorsing the approach to resolving the interdependency section. Are we comfortable to try and do that? I hope. I mean, do feel free to question these things. I don't want to later say, oh, I didn't really agree to that. And then the next steps, including the strategy writing and so on. So I think we're probably happy with that, aren't we? I think we've heard that people feel that. So I think overall, in summary, Alex, I think everybody's really welcome this. This is really good to see this, but I think there's a bit more engagement and refinement needed, probably, as you would expect. That's the purpose of bringing it. And then to think about how we start to embed this. I think if we're going to really, really make a change, we have to change our approach to how we think about citizen involvement, and we've got to move away. And I know local authorities are much better at this, but in the NHS, I think we've got so much over the years. We prepare something and then ask people what they think about it. Well, if we carry on doing that, we're not going to make any changes. This is the opportunity to say, what do you think? What do you need? How would you do it? And there for us to respond rather than the other way around. But it's a step change, and we'll have habits of the past to get over, and that'll be part of our own learning and changing. But I get the sense we're pretty comfortable with where this is up to, and it's a big step forward from where we were. Is that okay? So well done, Alex, and thank you to everybody. I've got a long list of people who've been involved, including Healthwatch and others. Thank you very much to them for engaging in this. Alex, anything final for you to say on this?
No, that's been a really, really helpful discussion, so I'm really grateful for that. And yeah, lots of threads to pick up to get that up to its next next iteration. So thank you very much.
Brilliant. Thank you. Let's move on quickly. Amanda and Rosa, I know you're going to help me now. Signature schemes and embedding the ICS outcomes framework. Over to you.
Thank you, Kathy. So these schemes are talking about testing and trialing new ways of working. That's exactly what these are. And I think there's been really good progress made in terms of engagement, for want of a better use of the word, but getting a common approach, a common view across the system to sort of provide a foundation for us to work really differently. We're not yet seeing impacts on outcomes that we can measure, but I think this is a good foundation for us to work really differently on, and we'll reap the benefits of that collectively, our people that we serve will. So in terms of the community transformation that Tim referenced earlier on, a co-design council has been established and is very active. There's been quite a bit of engagement and gathering of views over the summer. This is jointly led across health and care, across our whole system. And there have been a number of workshops which have resulted in a blueprint. That's going to be sort of tested and more over the next couple of months with a wider audience. And then the intention is that from January, there'll be a 100-day cycle of implementing the transformation. And that relates to workforce and data integration, working with the communities, cultural development, and tackling inequalities. So I think there's going to be some really valuable learning from how that is done in the early part of next year, ready for the next sort of financial year. For children and young people, again, this is a potential game changer in terms of how we look at complex care and placement needs. And so although we've focused on the sort of complex end, quite often there are disconnects between what the NHS might do in terms of disease treatment or illness treatment and social care services, and there are gaps in terms of the complexities of some of the needs of people who are not ill but don't fit into sort of either category. So this more joint approach, wrapping around services, I think will reap some benefits. And as you can see from the paper, there are some more upstream interventions as well, and particularly the mental health support teams are very forward thinking. In terms of the more personalised commissioning, this is another further area where, again, the way that health and social care work together can really, I think, change how for the better, actually, with a much more personalised approach. And again, mental health is a key area of focus here. So you can see from the paper that 365 sort of aftercare, section 117, or the aftercare when people have been sectioned under the Mental Health Act, went through that process with a really different approach, and that will continue to be built on. So this is about reshaping how we all work together and how we work in a more outcomes focused way. So I don't know if, Rosa, there were a couple of sort of practical changes that you wanted to highlight just to bring this to life, but that was all I wanted to say. Thank you, Kathy.
Thanks, Amanda. So it was really interesting hear Hugh talk earlier on about the strengths-based approaches in terms of looking at what's wrong with you to what's strong with you, because that integrated person-centred commissioning work with our local authorities is very much based in that. And one of the other areas we're looking at as well as mental health is around working with colleagues in end of life to look at how we maximise joining up care for people who are at the end of their life. And I just wanted to share an example from that. We are pulling together a book of stories of people's experience of this different way of working, but actually where somebody who was in receipt of care in a residential home following a diagnosis of lung cancer had, through actually very little being done apart from a very different approach with a shared person-centred assessment that was done jointly between local authority and clinical commissioning group colleagues, but really centred around the person, and then a really integrated budget to meet that, rather than one person paying for something or thinking about who pays for what or how we pay for things, looking at how we delivered what that person needed. Managed, after a fairly lengthy period in a residential home, despite only being in her mid-40s with a young family at home, managed to get back home. And the impact on that person's life of being able to be at home with their family, surrounded by loved ones, was incredible. And actually, the cost of doing that was the same as the cost of each of us commissioning our bit of a very traditional approach to meeting people's needs. So one really small example, and I have many that I could give, but recognise that we're constrained by time, but of that starting with the citizen and what they need to achieve the outcomes that will bring them the best possible health and well-being, and then looking at how we deliver and achieve that collaboratively.
Thank you, Rosa. Thank you, Amanda, for that update. Is there any comments or questions on this? We're trying to keep these things going whilst we're doing lots of other different things as well. So, Melanie.
I think, Kathy, these are going to be absolutely crucial for demonstrating why we have an integrated care system, is my view. So if I just take children and young people, because I think Rosa set out quite nicely the personalised care, and Hugh earlier and Tim about the importance of a community approach rather than a treatment acute approach. But I think it's one of our national scandals, isn't it, that 16, 17-year-olds, particularly with mental health, learning disability, autism, are being placed hundreds of miles away from home, often spending several days in ED or in a paediatric ward before finding somewhere that's safe and appropriate. So I think having that focus on those kind of things, because that touches on all of us. So whichever bit of that system we're in, whether that's my AMP service, whether it's children's social care, whether it's the acute hospitals, I think getting those bits right, I think will really demonstrate why we're here. So I'm quite pleased to see them. So just to sort of reiterate my support for them, really.
Good. I'm pleased to hear that. And thank you, Amanda, and to you for, making sure that people are continuing with these. I think, again, a bit like we said earlier about the capturing the stories, I think we need to capture the stories from these and be able to tell those, because that's actually what we'll know whether we're making any difference. Obviously, we want to link it to the outcomes framework so we can start to see how we might shift things and achieve those big ambitions we have about reducing inequalities and improving quality. I don't see any more questions on this, and given the time, that seems fine. The ICS board is therefore asked a few things on this. First of all, to note the work that's continuing in these areas. Secondly, to note the routes have been taken to embed an outcomes approach across these areas of planning, commissioning, service transformation and prevention, and also to note joint work being undertaken with system analytics and intelligence to measure the impact of these signature schemes. And that's critical, isn't it? The impact of what we do and being able to measure that. Are we content to note those items there? Again, shout if you're not. Don't go away wishing you'd said something, but that's super. Thank you very much for that. And moving on to EMOC, East Midlands Want Care. And I think I had down, well, Andrew Fern was going to leave, but I don't think Andrew's with us today. Is that right? He's not able to join us, but I think we've got Jonathan Lee and Andrew Hoare. Can I hand over to one or both of you to introduce this paper? Assume we have read it, of course.
You can, thank you. So firstly, I'll just quickly introduce myself. I'm Jonathan Lee. I'm a head of finance working in the ICS and also the finance lead for all things digital across the ICS, hence why I'm here. Andrew may stay off camera because I know he's got a few connection problems, although I can see him at the moment, but I'll let Andrew quickly introduce himself and then I'll move into the paper.
Hi, I'm Andrew Hoare. I work for Andrew Fern and I'm the interoperability lead for the ICS at the moment.
Okay, thank you. So Andrew's been heavily involved in this for some time, and is on hand for any technical questions that I'll fail miserably at. But just very quickly, I joined the meeting whilst you were talking about dry subjects. Apologies, it is slightly dry, but it's also a very exciting opportunity that we're talking about today. So East Midlands One Care is a partnership of ICSs and EMAS across the East Midlands. And the purpose is to develop a shared care record. To set a quick bit of context, we have 58,000 patients coming over into Nottinghamshire to receive care in some form. So a big chunk of those, particularly coming from Derbyshire, around 36,000, and 14,000 from Links, and then one or two others from Leicestershire and Northamptonshire. Patients going the other way, so patients that reside in Nottinghamshire going into other areas, it's around 7,000. What this solution will give is a shared care record for those patients. So in terms of that information that clinicians will have to hand will be far greater than what they've got at the moment, and the benefits I'll come on to. In terms of the progress to date, the partnership, the EMOC SRO group, have signed off following various other working groups around the technical design and the finances and the business case, have signed off in principle to commit to the solution and the PMO approach to implementing that solution. The ICS FDs are agreed in principle to support this solution, subject to all ICSs in the partnership also signing up, which makes sense. It wouldn't work properly without that. So other ICSs are going through a similar process in terms of stuff that we are doing today. The Digital Stakeholder Board within Nottinghamshire have also supported this solution. So that's how it's progressing. In terms of the case of need, I think it's all laid out in the paper fairly well, particularly on page 5. So I don't propose to go through each benefit at a time. It's predominantly a non-cash solution. So these solutions are about trying to manage future demand, whether it be numbers that are conveying from EMAS or other things. That there could be some cash benefits when you start to think about things like reducing duplication of medicines, where a patient's record states that they've already got medication, then the likes of NUH won't need to provide more upon discharge. So there could be some cash releasing benefits. I'll move on to the all-important bit, which is cost. So this is a 7.5-year commitment that we would be signing up to. In years 1 and 2, the costs are greater because of the implementation. So 255,000 in year 1 and 194 in year 2, and then it drops to 119 thereafter. We're in ongoing conversations. I say we, the partners of EMOC, are in ongoing conversations with NHSX around options to fund some of this. So if anything, those costs could potentially reduce if those conversations go well. As many of you will know, there's a national dilemma around digital funding between capital and revenue. This is clearly a revenue cost, and all the funding's capital. So that's the discussion we're having with NHSX. So just to give a bit of context, there's a number within the business case. There's a number of patient stories, and I think it's probably worth sharing one where a patient who lives over the border could potentially be admitted into NUH, and the information is not close to hand, because we have to request that information from cross-border services, that they've got a respect form that says they wish to die at home. The timeline between getting that information could potentially mean that that's not the way things pan out. So that's just one example. There's many others around mental health patients coming across the border and so on. And particularly around hospital discharge, the information that this will provide will certainly help in terms of speeding up that process, avoiding delays.
Jonathan, I think in the interest of time, we've got quite a few other things. I'm going to have to get you to draw to a close there because we need to move to any questions and then the recommendations. And I think we just ought to think also about South Yorkshire as well and how we handle South Yorkshire. So I think that would be important. So just a very quick wrap up from you and then we'll get on to any questions.
Okay, sure. So in terms of next steps, the ask is around supporting the commitment to delegate the responsibility to the system exec group to sign off on the business case, subject to final sign off by the FDs, and support the case in principle.
Thank you, Jonathan. So a really good thing, isn't it, this, to get some sort of shared approach. It'd be good for patients. Any comments or questions from anyone? Idris? We can't hear you for some reason, Idris. I don't know why that is. Not obvious why. Could you, I don't know what we can do about that. Joanna, help. No idea. It's the same problem, I think, that Nicole had earlier, I suspect, whatever that is. Can I leave you to try and sort that out? And I'll just ask Rupert to come in there and then we'll come back to you, Idris.
Yeah, thank you for the report. Yeah, I'm really supportive of this. The more people have access to records across a broader system, the more treatment options and care options open up, and they're often much better for the patient, much more focused around the need, and often better value for our system. So, I'm really supportive of the direction of travel. I can't speak to the detail of this specific system, but the principle behind it, I'm really supportive of.
Good, thank you, Rupert. Idris, if we haven't got you back on, I think Paul Devlin suggesting you type in your question, if you can possibly do that, that would be great. And while we wait for that, is everybody broadly content with the direction of travel and also then delegating to the system executive group? So in other words, the collection of executives to make any decision on this, and it will come under the auspices of our digital, presumably Andrew Fern as the leader overall. Is that right, Jonathan? Yeah.
That's correct, yeah.
Okay, good.
Sorry,
very good.
Idris will ask about Bassett Law. We have raised the Bassett Law point with EMOC. Initially, we need to go live with the existing ICSs, but there is scope to extend in due course. And I think that will tie in with the wider ecosystems platform solution that we'll be discussing.
So Bassett Law is part of our ICS, just for the avoidance of doubt.
Yes.
So could we take that offline? And Amanda, could you just make sure that we oversee that makes sure that Bassett Law is absolutely part of this right from the get-go? We don't have to deal with the whole of South Yorkshire at that point, but we need to think about flows there as well. But is that okay, Idris, if we make sure offline?
Yeah, that's fine. Thank you.
Oh, you're back with us.
Oh, excellent. Well, that was my question. Thank you.
That was it. Oh, brilliant. So we'll leave you with that. So I think we've agreed, if we for the notes, if we can just write that, key thing is that we have delegated that responsibility to Amanda to that SEG. So that's great. Thank you for that, and thank you for the paper and eloquently telling us about it. Thank you, Jonathan. Very helpful. Just moving on to the next thing, if I can ever get my things to move when they need to move. The next thing is, the IPR. So the Integrated Performance Report. Amanda, I suggest that, we accept that it's been read and highlight the key things, if you wouldn't mind. Thank you.
Yes, thank you. I'll actually keep it really brief and then take any questions. So I think just a couple of key points. One is that clearly, in the report, you can see that we're balancing a number of emergency care demands with COVID demands and the recovery of elective waiting lists as well. And then quite a careful balance around some of our workforce challenges as well and constraints. We have a number of transformation and efficiency schemes in place which are led by very senior leaders across the system, all with clinical and subject matter expert leadership as well, with coordinating programme directors. And also we're very just about for the NHS part of the system, we have been asked to submit a plan for the second half of the year following the financial settlement for the NHS over the winter. And I did just want to highlight again the workforce challenges. I think we can't underestimate the extent of attention that we need on staff wellbeing after a very long and protracted period of working under considerable pressure. Thank you. I can talk in more detail about anything, Kathy, but just to point out a couple of points. Thanks.
Thank you. Are there any comments or questions? I imagine most people are very familiar with much of the content of this and are kind of living it really, but I don't know if there's any particular comments or questions. I mean, I think that, if I reiterate what I've said many times before, there are three things we need to do between now and April. One is absolutely deliver on our operational commitments. So we've got to make sure the population gets properly vaccinated, that, we've got all these operational pressures in terms of the winter and recovery. Build the ICS as we've talked about, and then also things like the signatures scheme. So this is an absolutely key plank, isn't it, of the day-to-day doing, and I think the winter is going to be particularly challenging for us across the system. And we can see the imperative for our patients and citizens of what we need to do. But are there any other comments or questions for anybody, or for Amanda? Rupert and Adele.
I've also got my hand up as well there. Kathy, Paul.
Oh, have you?
Yeah.
I'll come to you as well.
2 points from me, Kathy. One thing, as we're here, it is probably right that we report that all systems are being asked to look carefully at ambulance handover performance as well. And so there's work for us to do to make sure that we're doing our best for the ambulance teams as well in the that service our area. So there's a kind of national imperative around that. So that's one to note. I think the other thing I'd say, and I say it everywhere I go, is that the pressure in terms of bed pressures and the ability to discharge as promptly as we'd want remains as high as it's ever been almost. And that's a thing that's really important for us to get a grip on as we go towards winter, because if we can't kind of make further inroads, and in fairness, there's a lot of great endeavour to try and get round the issue, but if we don't, then we're going to really, really struggle. So I just wanted to make that point. Thank you.
Yeah, and Rupert, yes, thank you for making the point about the ambulances. That is a huge issue, and that's all about really risk, isn't it, and where the risk sits to patients, those who haven't yet been collected from their homes and so on. So I'm sure everybody will be working hard on that. On the discharge thing, that feels something the system can work together on. And it'd be, an interesting question is, are there different things that could still be done? Not necessarily for answering this minute, but I think that's the question. Is there anything else that can be done right now, which is, towards the beginning of November, but, imagine January, it's going to be quite challenging. So I would just ask that if everyone can go away and think, what else collectively can we do? Go on, Rupert, you're going to say something.
Yeah, I think it possibly cuts across some of the other paperwork, but there has been some cross-system discussion around that through the summits that have been held, and I think the very question you're posing, Kathy's been posted into some of the groups that are there to deal with that, and I'm sure we can report back on that to future events.
Okay, thank you very much. And we do have something on winter coming up in a moment. But let me take Adele and Paul. Apologies if I've taken you in the wrong order. I might have done. But anyway, Adele.
Sorry. Yeah, it's just a quick one. Is that I know figures have been so to put. I think it's on page 88, the financial bit. It says no figures available for Nottingham City. I think they have been submitted. Well, I know they've been submitted, and I think there's an issue of alignment with the way that they need to be presented. From what I'm hearing, it feels like that's something that we could resolve. So can I just ask that we commit to working to get the numbers for the city in the report, because it doesn't feel right when we're talking about system integration to not have numbers from the city in there. So thanks.
That's really helpful, Adele. Thank you. And I'll leave you with, I guess, Amanda and Stuart to pick that up with you. Thank you. Paul?
Thanks, Kathy. I just think the integrated performance report should be a real sort of key focus for us as a board, and I'm not sure we're doing justice to some of the headlines in there in terms of the way this is reported at the moment. So just for example, in terms of the highlight graphs and tables, etc., the progress against system plan, there are a number of red rated items of progress. And I think from a board perspective, we're getting that this feels like we're being shown that we've got these challenges. We're being told what the challenges are, but actually getting that sense of what's our grip on resolving this? What are we actually doing about it? How are we going to know when we're going to get there? What's our confidence in getting there? I think that's something that I'm more familiar with seeing in an IPR, because then as a board member, it gives me more to get hold of in terms of actually getting scrutiny and assurance. So it's just a plea for how this gets brought in future meetings, which from what you were saying at the start of the meeting, Kathy, actually I won't be around the table anyway. So, but it's I just think for the board to be really doing its assurance work, there needs to be a bit more of the so what in there. And actually really saying, what are we doing about some of these high level risks that underpin the red RAG ratings? Thanks. Again, I don't need a comment in detail from colleagues, but it's a flag.
Let me just comment something that you're absolutely right, and it's exactly in the future I will want a very, very different thing at an ICB, a very, very different. So, you know, if you're in a trust, you usually use SPC, you would be using tracking of things. You'd also have a section on says it's off track, this is the mitigation, this is what we're doing, and this is the impact we expect it to have. So we need to move in that direction. At the moment, though, and in fairness, we're betwixt and between, because actually a lot of the accountability sits with the CCG, Amanda, doesn't it, at the moment, rather than us as a statutory body. So it's a very strange bit of world at the moment, but I completely agree. And of course, we would spend a more appropriate time on it at that time, because we wouldn't have things about building the system and all that sort of thing. So I think we're just at that funny time, but I totally agree with you. And it also needs to absolutely look at system things, not what individual organisations are doing. It's about the system measures as opposed to that. So yeah, take that point completely, and it will look very different. And that's something we're going to have to work quite hard on, I think. Paul said something about cancer wait times, Paul Robinson. Anything you wanted to expand on that, Paul?
No, it was sort of support Rupert's comments as much as anything, but it's probably also more as pertinent to winter planning.
Yeah. Okay. Good. Yeah. And somebody's suggested more focus on primary communication. I think it just needs a revamp for the future, really. I think I would say is that it's useful at this point in time, but we've got a different world to move into, and we've got a little bit of time to do that. So thank you very much for that, Amanda. Amanda, I think it's still you, isn't it, for the next item on winter, which we sort of strayed into slightly, haven't we?
Yes. Okay. Thank you, Kathy. And yeah, I'll just say I agree with all the points that were made. So So in terms of the winter plan, there are a number of strands to this, and again, I'll give a highlight and then pick up in detail. So as part of our planning, we look at our operational processes, we look at how we escalate between ourselves, and we're continually having to adapt how we work. We also model what we think the capacity and demand will be. And in terms of, I think the challenge earlier around discharging patients from hospital in a timely way, we are at this. We have a cross-system group in place, and there is sort of chief exec challenge on this very regularly as well. Around, are we doing everything? We are doing a lot around maxing the capacity where we can, bringing more capacity online, looking at the processes, which are everywhere, across the whole of the system as well, because bottlenecks can happen anywhere. And there are a number of sort of particular constraints which are listed there around the additional COVID bed requirement and the social distancing requirements and managing outbreaks, elective recovery, which we need to protect as much as we possibly can, as well as the home care market and waits for packages of care. Increased mental health demand and increased demand for paediatric emergencies as well. So there are a number of mitigations in the plan, as you'll see. Some of them are around trying to manage the demand as well as we can. 111 first and redirecting where appropriate, linking 999 into those other pathways as well. A 2-hour crisis response in the community. And same-day emergency care as well. There are some of the examples, as well as looking at the streaming into primary care and managing people at home through a joint multidisciplinary approach where we can. So those are just some highlights. So there's some things, as I say, around processes, escalations, grip, managing the demand and diverting the demand where that's appropriate, but also the flow through the system and discharging people in a timely way. So that's just some highlights, Kathy. Thank you.
Thank you. Again, this is probably something everybody's very familiar with, but I've got a couple of people come in, John Towler and then Richard Henderson.
Thanks, Kathy. So quickly, if I look at the key risks, the home care market appears to be a key risk. And there's reference to pathways to put additional capacity in place. But I suppose my question is, if that home care market's a key risk and our solution is to, quote, stimulate it, are our plans credible?
So I think it's fair to say we've stretched all of the things that we can do this year, and there is a sort of more of a rethink around what haven't we done that we could do. Workforce challenges are, because what we don't want to do is stimulate one part of the market and then people just move from one part of the system to the other. So it has to be done in a very joint way. And that's why the discharge work is jointly led between the NHS and social care as well. I don't know if Melanie might want to come in on that, but it's something we're picking our way through. We're doing all the things that we can possibly think of and picking our way through thinking what else can we do differently.
Melanie?
Yeah, so as our key risk and issue, I think I'm more aligned to John. So our fundamental priorities is about supporting the workforce, whether that's our own, including our mental health workforce and our communities and social care services. So the hospital discharge bit it's a tiny bit of the overall significant risk. We've got about ensuring people are safe at the moment and their human rights. So we've got a fundamental capacity issue there. So it's not as simple as stimulating the market, but I'm happy to have a conversation offline. But yeah, our key risk and issue is just general capacity. So the flow, I know, is a particular concern for some of the bits of the system, but ours is more about maintaining that quality of care at the moment, with handbacks of care at weekends, care home closures.
It's a big issue. Presumably there is somewhere where this is all being looked at across the executive, across management. across the system, because we're not alone in this, are we? But the workforce is every which way you turn. This is one of our really, really major risks. But I think you're right, Moni. There's a potential to look at the tip of the iceberg here, and actually there's a great big bulk of it under the water, isn't there? As you're saying, the people in their homes, and if that falls over, well, where will people go? And that could make it all 1,000 times worse, really. So I suppose, John, what behind your question is what are people really going to do now about this in order to bring the best possible mitigations to this big risk? Is that right?
Yeah, it feels as if that's a key block that needs to be successful. And I suppose I'm failing to take assurance that we have real plans.
Mm. So, sorry, I probably didn't make this explicit. What we're doing is some of the capacity that we are bringing on in addition is a workaround so that we can at least move people from hospital. Ideally, we'd want them to go home, but they will be going into interim placement. So that is it's a sticking plaster to manage the pressures. It's not the longer term solutions. The longer term solutions are more about how we can make the recruitment and retention attractive, and that is work in progress in terms of that part of the plan.
Okay, so we've obviously got full knowledge of all of that, but it's a challenge, so thank you. I'll take Richard and then I've got Eric.
Yeah, thanks, Kathy. I think one risk that we really need to be cited on is around the regional impact of ambulance handover delays. And I appreciate Rupert and Paul describing the Notts position, which ordinarily isn't a major problem. But what we do have in the region is among some of the worst performing hospitals in the country for handover delays. So, of course, ambulance provision then gets taken from Nottinghamshire to those areas, but also you'll have patients being brought from those areas into Nottingham. So that's something we do need to keep sighted on, otherwise it will disproportionately affect, and there's a high degree of unmitigated risk for patients in the community. So I do think we've got to keep a real focus on that regional aspect of ambulance handovers as well.
Yes, thank you. And that it is a major national thing, and it will have an impact. Thank you for that. Eric.
Yeah, mine's a kind of simple question. I don't think there's an answer to it, but the paper gives a lot of things we're doing. What I don't get from the paper, I don't know how assured we can be that we're going to be able to get through the winter. I mean, I'll just put it as brutally as that. I'm sure people are working on it, but I don't think there's enough in here to give me that assurance that I would normally be looking for.
Yeah, I think, and we can't really resolve that here now, but maybe, Amanda, you could take that away. I think what we'd really be looking for, to be assured, certainly from a non-executive perspective, you're usually looking for what's the issue, what's the action, and what impact do we expect it to have? And can we track that it's then having that impact? And we probably haven't got enough here.
Yeah, I agree with that, Kathy. And also, what's going to be the consequences of not being able to manage it? Because we can't see that at the moment either.
Yeah. So, Amanda, can I leave you to take that away and perhaps discuss that system executive or whatever, to say how can, what's our realistic position here on this? Because I think the winter is going to be very tricky, and we'll have another round of this, even if it's not at this forum, that there needs to be, we need to be able to oversee that. But good, thank you for bringing that forward. Now I'm really conscious of time, and Stuart, Rosa, and then John, I think you're going to absolutely have to assume we have read the papers, but Stuart, do you want to pick up the finance group report? Any key things that you need us to be thinking about?
First half of the year, we've got a deficit that we need to recover in the second half of the year. That's going to be a challenge if we are to deliver all of the things in the planning guidance. We've got some unique challenges in Nottinghamshire around elective recovery and the way that was funded. We are having some really positive conversations with the regulators about that, and I'm hoping that we can find a resolution and put a balanced financial plan in the next couple of weeks. Thank you.
Well, that was very nice and short. Thank you, Stuart. Any comments on that? I mean, does everybody in their own organisations understand this and are contributing across the system on this. I'll look at Rupert, Paul.
All systems are. I can confirm. All organisations have worked very well on this. I can confirm.
Okay.
Yeah, I agree with Stuart on that. We've all chipped in to try and get the best position.
Okay, well, we note that, and obviously we'll be looking for progress against those issues over the next period of time. So thank you, Stuart, for that. Anything else you need to say?
I suppose the only other thing is we had a conversation last time about a more detailed financial review, and clearly as this is the last meeting, we can't program that in, but I'm very happy to take that offline or in a development session or something to go through in a lot more detail, because there's a huge amount of detail behind these summary positions, and it's obviously very difficult in the time that we have to go into the detail that some people rightfully want. So
of course. Yeah, thank you, Stuart. Thank you for that. Can I move on to Rosa? Again, same approach, if we wouldn't mind.
So I'm not going to discuss the areas where we've had enhanced surveillance at the last meeting, which continues. I just want to highlight to partners, as Melanie referred to in her earlier comment, we do have some concerns around the care sector, both the capacity and availability of the workforce, clinical and non-clinical, and the impact that has on our ability to deliver the fundamentals of care and quality. So whilst we have a really strong system working around that, we will be looking at that in much greater depth at our next meeting to gain further assurance about what we might need to do to maintain quality in that area. And then the other area I'd like to highlight is our Learning Disability Autism Partnership, where we do note there's a difficulty in meeting our planned inpatient discharge trajectories, but where Melanie, myself and colleagues from Notts Healthcare Trust are leading a whole system approach to how we look at that work, both at discharges, but beyond discharges, to the quality and safety of the care that those people are receiving.
Thank you. Any comments for Rosa? Comprehensive paper there on a wide range of areas. Thank you. We'll note that. And then on to John, the Transition and Risk Committee. Some of the things I guess we've talked about, but over to you.
I'll try and do my normal 50 words or less, or 50 words or fewer, I should say. So the transition plan remains on track, and we've confirmed to NHSEI that that is the case with our most recent submission. I think we'd want it to be understood, however, by members of the ICS board that what we still have to do is complicated, it's resource intensive, the timescales are challenging, particularly the amount of work to get through before Christmas. And national guidance does have a tendency to get delayed. So I think as a committee, we feel that we're in a position that one or two dominoes falling the wrong way could cause several others to fall too. So as a committee, supported in particular by Rebecca, we need to keep a very close eye on the detail of where we're at, and we commit to doing so.
Thank you. Any questions for John on that? I think we are making good progress, and I think we've referred to that a few times. I think you did want to ask for continued oversight of finance and digital in terms of assurance, which I think, and people, I think, which we've given the committee for a period of time, but I think it would make sense to extend that. Is that right?
Sure. I think we proposed it to you and you offered your support, so I presume that was enough.
Good. Well, we'll say that that's what we'll do, because there's nowhere else really for it to go at the moment. So it makes sense, given we're so close to a new world coming to us, or us creating a new world, that if that's okay, John, with you, I'd be very grateful if you would continue to do that with your colleagues. And thank you to everybody who's been working on that. So thank you. Thank you. I apologise that that bit has been a bit of a hurry through, and probably people feel we're not. Oh dear, I'm sorry, Boyd. I do hope you feel better soon, but please, yes, go and recover. Thank you. We've scrabbled through those, but I think as the agenda gets cleared out from these kind of meetings of the creating things, we'll have more time for the actual business. So thank you for your tolerance on all of that. Fine. So questions from the public. I believe there's none being sent in, Joanna. Is that correct?
That's right, Kathy. We haven't had any questions for this meeting.
Okay, thank you. So that takes me to almost the final thing, which is review of the meeting against the partnership agreement. I highlighted at the beginning that we should focus on that, and I think usefully along the track we also picked up around you know, those things that came from our citizen story, those key things of citizens at the heart, and so on. Any comments on whether or not we've met our principles around citizens and ambition and thinking about system by default, or comments on our values about openness, honesty, respect, and accountability? Anything anybody wants to add tonight? Comment on any of those? Or that we didn't, for example? That would be helpful. No, all right, thank you for that. That's fine. So the final thing I was going to say is that, you know, this is the last of the public sessions of this board, but we have got a development opportunity session, I think, in December, haven't we, Rebecca? We've got some other things coming up. Obviously, we've got the thing at the end of November, and we've got opportunities in December. One of the things, and I've asked a number of people whenever I sort of run into you really, is what will we do as a system to ensure that we maintain the good relationships and the working together? And chairs and elected members, we discussed it the other day. I don't think we have an absolute answer, but I think we need to think about both the transition and then beyond. And there may be more we need to do in transition until we're up and running with an integrated care partnership and the things that relate to that. But it'd be a total disaster from my perspective if we kind of went away and said, that's it, you know, we're not working together like this anymore. We'd have shot ourselves in the foot. All the good work would be unravelled. So do think about what we might do going forward to ensure that this kind of group of people remains linked, and that we don't lose that building of trust and so on. I don't have an answer as such, but I think there is something worth thinking about, a transitional period before we get the future. Okay, Amanda, was there anything you want to say about that?
No, I think it would be good to hear people's views about that, but I agree it's going to be really critical. So we do need to do something, as you say, during the transition and then beyond as well. Thank you.
Okay, thank you. Tim, did you want to come in?
I just put it in the chat, but just to say so it's on record on YouTube. Part of the answer is to remember the vertical dimension of the system. And even if these relationships stop at this level, they're going to continue at place and PCN level. And at that level, the trust is getting just stronger and stronger every week. So
great. And I think that is part of the answer, that is probably the answer. But I just wanted to give people an opportunity to reflect on that. And then to say a big thank you to everybody who's been on this journey on this board for a longer period than I have. But certainly I thank you for all of that, and in particular from my perspective, from the time since I've been here. So that sounds a bit final, but it's just, this thing is ending as in this format. So I do want to acknowledge the thanks to everybody, and I know you've put in a lot of time, commitment, and things are moving forward. You know, it will finish knowing we have made some significant progress. So thank you to everybody.